Hello, everybody. I'm Audrey from Melanoma. I'm not. I'm Audrey from Ocumel UK, and sitting with me is Dr. Joe Sacco, who is a medical oncologist from Clatterbridge. And I think it's safe to say for us from Ocumel UK that he knows just about everything there is about the trials that we know about. So we're going to talk today about treatment options for metastatic ocular melanoma. So do you want to kick off, Joe?
Thanks very much. So thanks for the invite. It's very kind of you to ask me.
It's a pleasure.
And then to harass me into actually doing it.
Several times.
So would you like me to just get going on that, or do you want to ask me?
Please. Would you mind if you just chatter away and I'll interrupt, because I'm good at that.
Thank you.
Okay, thank you.
So I think in many practices, in many of you will have been having regular surveillance. That means scans to detect whether there is evidence of the uveal melanoma spreading. And obviously, a large proportion of people, this isn't the case, and that's partly why we do it, for the reassurance. But in the case that we do pick up metastases, there are a number of options that we would then be looking at. Unfortunately, we don't have a standard of care for uveal melanoma, and it has been somewhat neglected, but we do have a number of options. So just to be aware that this may be different in different regions, but also across the world. So the first thing is, can we detect it at a stage where there is only a small number of metastases that can be removed by surgery? This is a smallish proportion of people who have that at the original diagnosis, but in some people that is the case. And if we can remove a bit of the liver that contains the cancer, this can lead to control for a longish period of time, by which we mean control for some years, hopefully. It doesn't seem to get rid of it entirely, as in it does tend to come back in a different part of the liver given time, but sometimes again can be resected at that point. The other option that may be discussed would be the possibility of ablating these. So that's using what's called radio frequency waves or heat or something like that. So you put in a probe, like a long needle, into the lesion itself, and then heat it up so that you kill off the tumor without having to operate and so on. And this can be also very effective at killing off local areas where it is involved. However, if it isn't possible to do one of those other things, then it's normally because it involves too many areas of the liver to really be treated through a local approach. And then we look at two different sort of global strategies, one of which is liver-directed therapy, which you'll hear a bit more about later today, but also in terms of a systemic therapy. So that means, when we say systemic, it means treatment that goes all over your body. And this can be delivered by tablets or by infusion through the vein, for example. In terms of the loco-regional or liver-directed therapy, there are a number of different approaches to this. Many of you will have heard of DELCATH, which, as well as CERT, and which is a form of directed radiotherapy, but also can be chemo that is directed in there, or bland embolization, which means just sort of beads to try and kill off areas within the liver. So I won't talk much more about this, apart to say that this will be covered in depth by the talk later today. The only thing to mention is that it isn't, because it still hasn't been adopted widely in the UK in terms of funding, and it isn't actually licensed in the US, for example. This is still, mostly considered experimental and isn't widely available. I would agree that there is definitely evidence for benefit for some of these approaches. And I'm hoping that the clinical trial that's ongoing, called FOCUS, will lead to a change in that, will actually provide enough evidence to support what we call registration, which basically means that the authorities in the US would be FDA, and in Europe it's the EMA, in the UK, it will become the MHRA, which will have the sort of say-so to say this drug is good enough to be used and widely. And then we have the further barrier of NICE, which would then look at it and decide whether it is cost effective. So I'm going off piste a bit here, but
no, that's absolutely spot on.
Background, because we need to know what would be available for people in the UK as it stands. And that can, there, some of these options can be available privately. Obviously, that is not how I would hope medicine would be provided in the UK. But there are different levels of criteria that various insurance companies, for example, have compared to NICE. So leaving that to be discussed in more detail later, the systemic options are really where I'm most of my expertise is. And at the moment in the NHS, outside of clinical trials, we're talking of two different main treatment options. One is immunotherapy and the other is chemotherapy. These work in very different ways. So immunotherapy doesn't really attack the cancer directly. What it does is stimulates your immune system to attack the cancer. And this has really been through what we call the immune checkpoint inhibitors. It's quite complicated biology, but basically it means removing the brakes on your immune system. Cancer doesn't have a mind of its own, but because it develops from single cells that then mutate and change over time, there is, it's like evolution within a cancer. So the cancer cells that are able to grow and to survive the immune system are the ones that keep multiplying, whereas those that are seen and killed off by the immune system are removed. So that's why the immune system is evaded by the cancer generally, because in order for those cells to survive, they have to shut down the immune system. Our immune systems are incredibly powerful, generally speaking, as they can recognize just very minute changes on cells that suggest that they are infected or are foreign to our own body, and they can be eradicated. So these defense mechanisms that the cancer cells develop are important for the survival of the cancer. Now, we're not interested in what the cancer does, apart from how we can reverse that and make our immune system see the cancer better. And basically, this is what these checkpoint inhibitors do. There is a problem with uveal melanoma in this regard, in that it doesn't have many mutations. And this means that it seems to be less visible to the immune system than skin melanoma, for example. So even with immunotherapy, it's a very high bar to try and get the immune system to see the cancer. And as it stands, these checkpoint inhibitors called ipilimumab, nivolumab, pembrolizumab, and combination of ipilimumab and nivolumab have relatively low benefit. So they can work, but it is uncommon overall, and certainly a lot less common than in skin melanoma. So there's a lot of need to improve from where we stand with immunotherapy. And a lot of research is going on to try and get newer therapies in that regard. The treatment...
It sounds to me like immunotherapy tends to be a bit of a hit and miss system then, rather than a direct attack. If it's not finding, shall we call it the enemy, if it's not finding its target, then we've got problems, haven't we?
It is, yeah. I mean, so when it works, immunotherapy can be amazing because it gets your immune system on board. The immune system then controls the cancer, not for a week or a month or, but often for years.
Oh, I see.
In skin melanoma, once you've got the immune system on board, it often does that. The problem is with uveal melanoma, the likelihood of doing that is very low. But when you use single agent immunotherapy agents, for example, they are generally well tolerated. So the side effects are present. They can be severe, but many people get away without many side effects. Combination immunotherapy can be a lot tougher because there's around 50% of people end up needing to be hospitalized to manage side effects. So there's a bit of a balance there. The combination has a bit more benefit than the single agent, but it is at the cost of more side effects. So I would say that this is our standard of care. This is how this is de facto. It's, you know, it is what we have available, and I think has the best balance of side effects versus benefit in a treatment that we have available to us and has evidence for it. Now, in contrast, chemotherapy is looking very much at killing cancer cells directly. So it's like it's a poison basically with chemotherapy, not putting too much of a spin on it. And it kills cells because they're dividing. And every time a cell in your body divides, it is more vulnerable to poisons basically that stop it, that damage the DNA in it and then lead to cell death. So there the balance is with side effects is more, there are more side effects in my view, at least. They're different to immunotherapy, but they're also a bit tougher, I think. And they're related to other cells in your body, mostly that are dividing. So if you know, the blood cells that you need to produce your red blood cells, so you're not anemic, the white cells to fight infection, etc. All of these can be affected by chemotherapy. Also, nausea and vomiting is quite common because they're chemicals that can affect the brain, basically the stimulation that makes you feel sick. I'm not saying that all chemotherapy is not tolerable. People manage it quite frequently. The issue with chemotherapy is it tends, even where it benefits in uveal melanoma, it is for a very short period of time. It sort of holds the cancer back, but only for a few months at best. And even that is infrequent. So, you know, from what I would do would be looking at trials, which I'm sure we'll come to in a moment. And then after that, if we don't have trials ongoing, would be to look at immunotherapy as the first line of treatment, in the absence of, for example, the ability to do local, treatment that is directed at the liver. And then chemotherapy would be if we haven't had any benefit from immunotherapy, and with a discussion looking really clearly at the risks and benefits of whether it is worth trying that.
Okay, so chemotherapy is absolute last. Really.
Yes, I think so.
And given the side effects of chemotherapy, you're right. You do have to weigh quality of life. If this is the last ditch, then I would want to, as a patient, I would want to weigh up quality of life versus, that couple of months of not feeling well. Okay, I think that's really interesting. But you would you keep touching on trials, and I'd like to, if it's okay with you, could you just give us a little? I know that we're in the middle of COVID, and I appreciate that most things have come to a grinding halt. But could you give us a little snap?
Yeah. Well, I mean, I'm passionate about clinical trials, and the uveal melanoma is a difficult to treat cancer. I think partly because of the nature of the cancer itself. But I think a large barrier has been because it's rare. And so it's been difficult to do the studies to really show whether things work or not, and to then learn from where, where we are to get better therapies, etc. COVID has hit us very hard. We started out, we had all our trials stopped completely for a period of time. We then reopened, but everything's been slowed down. We're now in lockdown version 2. So, it's impacted on all of these different aspects. And that's really, really hard to take, because I think we need trials to get better, and we need them to provide other options to people who are in this situation. So when we look at the trials, I think we can look at a number of different approaches. There are liver-directed therapies like Focus. Now that's closed at the moment. It is now closed, sorry, so we're waiting on the results. But obviously we'd like to have more studies in that area to understand whether treatments into the liver are as good or better than tablets or infusions otherwise. We then have chemotherapy in general. We don't really have anything that looks promising at the moment in terms of trials there. Then what's called targeted therapy. So targeted therapies means normally when we've got a change in a cancer that due to a mutation or a different protein being expressed, produced at a high level, that means that we can hone in on that and try and attack that protein, gene, or whatever, and prevent the cancer from growing. While, because that is particularly changed in the cancer, it means that we hopefully won't affect the rest of the body to the same degree that we do with chemotherapy. So you might hear this sort of term targeted therapy. And in skin melanoma, the main ones are directed at this gene called BRAF. But in uveal melanoma, there isn't a mutation in a similar kind of gene like BRAF, or in KIT, which is another commonly sort of mutated gene. There is a mutation in a protein called GNAQ or GNA11 in many of these cancers, but it isn't directly targetable. So we can't get a lock on to stop that from functioning. We can only look at targeting downstream of that, and that's where drugs like the MEK inhibitors have come in. And we were involved in a study called CellPack recently, and have also collaborated with people in the States like Rich Carvajal for other studies with similar inhibitors. I think there is some benefit to these, but it is very marginal and isn't really, from our recent study, we didn't find enough benefit really to keep on going with that path. I think it slowed down the cancer in some people, but at the expense of more side effects, I think, and that's the issue, that it's that balance really, and it wasn't sufficient to do that. So I think targeted therapy will hopefully keep on looking for the right things to target and the ways to do so that balance benefits against side effects. So then in terms of immunotherapy, which everybody wants, that's where everybody is most interested in, because it has this potential for long-term control. We've been involved with Immunocore over a number of studies now, and particularly what's called the 102 and 202 studies. And these have both completed recruitment. So they've stopped new patients going on to it. The 102 study was what's called a single arm study. So it was everybody had the drug. Now, in order to, the drug itself is designed against a specific marker. So about 40 to 50% of people have a specific genetic makeup, which is involved in how cells show proteins from within them on the cell surface. So it's called MHC. And basically, it's the same thing that we use with when you have transplants and so on, because we've got these specific genetic makeups, and some of us are very similar in that regard, and some of us are very different. But one of these is called the HLA-A family, and HLA-A2, which is the drug is targeting, is around 40 to 50% of people in the UK at least. So this drug is trying to pull in the white cells to attack the cancer using a very, what's called a bispecific. So one end of it sticks onto the cancer cells and the other end sticks onto these white cells. And then when it tags them onto it, the white cells then are able to kill the cancer cell. And we think from our early data that this is quite promising, and I hope that it will ultimately become something that at least for that 40 to 50% of people will be another option that at least controls the disease for a good period of time. We don't have the study, as I say, nobody's being enrolled onto this at the moment. I'm hoping we'll get a new study in that regard sometime next year, but it's still in the pipeline, so to say. But we will also hopefully get the results from the study over this year. The earlier study, the single arm study, has results that will be presented next month. We can't present that data yet, but that will be available in about a month's time or so. The issue is that that's not going, because that's single arm, that won't actually lead to registration, which means we need to wait on the randomized study, which is the data that actually will support, hopefully, registration and funding for the drug. So the other agent I was going, the other trial approach that we've been involved in recently, which I think is hopefully going to bear fruit, is with Replimune. So they are a company that have developed oncolytic viruses. Oncolytic means basically killing cancer. So onco, cancer, lytic means rupturing them. And with oncolytic viruses, you generally need to inject the virus into a tumor, and then the virus affects the cancer cells, but not the normal cells. It then kills off those cancer cells, and then because it's killing cells, the immune system comes in, and hopefully that can then get educated. It's like a vaccination in the tumor itself. So you're killing cells, you're releasing the contents that then are recognized as foreign by the T cells that then go out and do their thing elsewhere. That's the idea. And with Replimune, they're engineering a number of these herpes simplex viruses to try and get the best activity possible. We do have one oncolytic virus that has been licensed in skin melanoma called TVEC, but otherwise it's mostly at the trial stage. So the idea is that these viruses can not only kill the cancer cell itself, but then stimulate the immune system, because the virus has been engineered to produce specific proteins that stimulate the immune system, and that will then work very well with standard immunotherapy to get a more general response. So there are 3 viruses in this family. The first one has been presented and I think showed some early benefit. We still for a few patients, but they're very early stage trials, so only a handful of people involved, and we're more hopeful for the second one, which is still really ramping up. Again, they have results from these 2 studies. Early results have been presented at this year's SITC Congress, and can be found there if you're interested to look at. Just Google Replimune and SITC, and that will take you to some details. It is challenging because it involves injecting directly into the cancer. So it's in Liverpool in particular, we've struggled to do that with the liver tumors, but we're working with our radiology colleagues to try and make sure we can do that as well. Because ultimately, we would like to see if there is some evidence of benefit in the few people that we've treated, to then expand that and ultimately to get a bigger trial specifically for uveal melanoma. And this is again digressing slightly. One of the big problems with uveal melanoma has been that the trials have been, less than 10 people on the trial, possibly with a drug that's being tested for cutaneous melanoma, and then it's just been taken over by the skin melanoma. It's never really been thoroughly investigated in uveal melanoma. So wherever I'm involved, I'm hoping to try and direct that towards it being a uveal melanoma specific approach as well.
Yeah.
The other thing to touch on is TIL therapy, because I think you'd hoped to have a talk on this as well today, but that hasn't happened. So I'll give you my sort of summary and
okay, that'd be really good.
That's helpful. So one of the other approaches is that we've been looking at in cancer treatment in general is to take out the cancer and then to break it up and to separate the cancer cells and the cells that are the immune cells. And then we can stimulate those immune cells, which we think are basically seeing the cancer because they're in the cancer. We stimulate them and grow them outside of the human. And then we can put them back inside, infuse them at hopefully we'll have increased the number by 10 or 100 or 1,000-fold or whatever. And so when they go back, they're then able to attack the cancer more effectively. It does mean when you're doing that, you usually have to dampen down the immune system by giving chemo first, and then you infuse the TILs, because otherwise when they come in, they are a very small proportion of the overall immune system. But by, well, reducing the immune system more generally, and then we feed these in, they become a higher proportion and then are stimulated to grow and attack the cancer. CAR T cell is a kind of variation on that, where these cells are removed from the body, but then they are engineered to attack specific targets and then infused back into person. So there was one study in the US by the NIH, the National Institute for Health, which had a small number of people, but showed some promising benefit to TIL therapy. It's very complicated and hard, it's done very in very specialist centers, very infrequently. And at the moment, there isn't really anybody doing this in the UK. There, to my knowledge, they are doing it in other cancers, but not in uveal melanoma. I hope that some of the trials will then be again more specific towards uveal melanoma, and there certainly are other ones ongoing in the US in that regard. So at the moment, so there is some promise there, but it is going to need more work and in terms of becoming more available. But the challenge is going to be whether that becomes, both in the delivery side of things as well as the science side of things. So the two sort of challenges. I guess not dissimilar with the oncolytic viruses, which I was mentioning, injecting into the liver. But I think that is a much lower challenge to overcome, which hopefully, if we can show benefit for that, we can ramp it up around the country.
Oh, thank you so much for that, Joe. That was very interesting. And as a patient, I'm at the moment feeling quite flooded by it all, because I'm thinking there's so much out there, but we are so rare. So and it's like you're saying, we're doing that. You're doing not you, but trials are being done, but with very small numbers. And I'm thinking, we're here, but unfortunately, that's the way it is at the moment. But it looks like that at last we are moving forwards with science, and as science moves forward, then we have the opportunity perhaps of something better on offer than what we have now. So no, I think you've made my day.
Thank you.
All right. Oh, thank you.
I completely agree. The science is, it can seem very dry and it can seem quite far removed from us, from patients. We all, one way or another, have to deal with how this would affect us. But without the science, without the understanding, then we can very easily end up with treatments that cause more harm than good, or no treatments at all. So, understanding is key. And the numbers issue, many cancers are 100-fold more frequent, or, even more. And so actually, well, maybe we'll cover this a little bit in our next talk about how we can look at evidence for rare cancers versus,
That would be lovely. Okay, then. So let's wrap it up for now, and I'll come back to you in a minute. All right.
Okay, that's
so
brilliant.
Thank you, everybody. And thank you especially, Joe. Thank you so much.